Thank you, Ron. It's my pleasure to be here this afternoon. So, as has been discussed, the risk of stroke following a TIA is front-end loaded. The risk is greatest in the first hours and days following the initial symptom. And if we're going to intervene at the sweet part of the curve to try and prevent stroke, we have to act quickly. So Ron has raised the issue of what makes an immediate difference in stroke risk. And there are basically only two things that are going to prevent a stroke that's destined to happen the next 2 or 3 days. First thing is to prevent clot formation, propagation, and embolization, because the vast majority of ischemic strokes are due to the presence and occurrence of interluminal thrombus. So that strategy is an antiplatelet agent for arterial sources of stroke or an anticoagulant for a cardiac source of stroke. That will help prevent or reduce the risk of clot propagation. The second thing that makes an immediate difference is fixing an artery that is symptomatic. A high-grade carotid stenosis is a high risk for an early ischemic stroke, and although the treatment in part is antiplatelet therapy, the definitive treatment is to treat the artery in question. And we actually have considerable data that shows that a timely and skillful carotid endarterectomy substantially reduces the stroke. So this slide is a meta-analysis of the two major surgical trials comparing carotid endarterectomy to optimal medical management. And the red bars that I'll just pop up on the screen here show the absolute reduction in stroke risk related to the timeliness of carotid surgery following a warning TIA. So as we see, if you're able to get the carotid surgery done within 2 weeks of the TIA, 0 to 2 weeks, the first red bar, there's an absolute risk reduction in the risk of stroke over 5 years of 30%. That's in absolute terms, and I'm not aware of any prevention strategy for any critical illness like stroke that yields a 30% absolute risk reduction. The longer you wait, of course, the lesser the benefit, because your patients have either survived the risk or more likely they've gone on and had the stroke that they were destined to. So by 2 to 4 weeks, the absolute benefit is nearly cut in half, down to about 17%. By 4 to 12 weeks, which is not an uncommon delay in our healthcare system to see a surgeon and get the OR booked and so on, your absolute benefit is really a third of what it was versus timely urgent surgery. And by the time you get out past 12 weeks, you're down to about a 9% absolute risk reduction. Now, the benefits for carotid surgery also occur in less severe stenosis, in less critical stenosis, the 50 to 69% stenosis. But because the absolute risk is lower in that category, the absolute benefits from surgery are less. But again, as you can see from this build on the slide, the green bars, the benefit from surgery, even in these less severe carotid stenosis, is optimal if you're operating within 2 weeks of the TIA. Still about a 15% absolute risk reduction in disabling stroke. Whereas if you delay and you're out to about 3 months, there's actually no benefit from surgery overall in this patient group. So early surgery is a challenge for us. It means that diagnostics have to be done. Referral patterns have to be accomplished. The patient has to be admitted. These are generally 1 or 2 day in-hospital procedures, but it all has to be done very quickly and efficiently, which means you need to have a well-oiled diagnostic process and a referral pattern. So the numbers needed to treat to prevent a major stroke with high-grade stenosis is really 3, which is an extraordinary NNT for a major clinical outcome. That's for severe disease, and for less significant stenosis, the numbers needed to treat are still very compelling, with the numbers NNT of 6. So what is the test? For most family doctors, the test that's most readily accessible, and probably the one you're most familiar with, is a carotid ultrasound, or a duplex study. The duplex terminology refers to the fact that you get 2 studies. And on the top portion of this slide, you'll see the color flow B mode, which shows the cursor is placed right in the middle of the critical stenosis there, and we get this mosaic of colors reflecting high-grade stenosis, and that allows the technician to identify the critical point, and then usually the degree of stenosis is determined by the velocities, which are shown on the portion of the study below, and of course the higher the flow rate, the tighter the stenosis. So that's something that can be done, but you do have to usually speak to your radiologist about it to get it done in a timely fashion. If you just allow your front desk to arrange this, you'll likely get a booking about 3 months away, which is not sufficient. Now, Ron mentioned we have other strategies, and I don't think it's critical what your first imaging strategy is. It's the timeliness of the strategy. So for a lot of us, we use the CT angiogram, which is on the left portion of your slide here, as a workhorse, and certainly in the emergency department, this is a study that can be done quickly and efficiently, providing renal function is good. The X-ray table time for a CT angiogram measures in about 6 or 7 minutes. We run these patients through routinely from our stroke prevention clinic. Tomorrow we'll probably do 6 or 8 of these as an unscheduled study to highly define the anatomy. On the right side of the screen here is a catheter angiogram, and you can see this is on the same patient. You can see that the image quality is very comparable, and so for the most part we don't have to proceed to invasive angiography. We can get all the information we need with CT angiography, and it's extraordinarily useful for other vascular territories like the vertebral basilar system, or to rule out aneurysms and other mechanisms. If you have symptomatic carotid disease, the gold standard for treatment remains skillfully performed, timely carotid endarterectomy. And this picture shows one of our vascular surgeons at work here removing the offending carotid plaque. It's basically a clean-out procedure. Carotid stenosis serves as a source of embolus, and so this surgery, for the most part, is designed to remove an embolic source. We have skillful surgeons. We have knowledge of the benefits of this, and providing the patient is a good surgical candidate and it can be done in a timely fashion, this is currently still the treatment of choice. And recent studies favor endarterectomy over carotid angioplasty and stenting in appropriate patients. However, this is an angiogram of a high-grade carotid stenosis, which you can see on the left portion of the screen, a tight critical stenosis there. This is pre-angioplasty and stenting, and on the right side of the screen is post-angioplasty and stenting. This is an option that is available. We have several skillful interventionalists from a variety of different career paths: neuroradiology, interventional neurosurgery, and some cardiologists doing this. For the most part, we select patients carefully for this. These are usually patients who are high surgical risks, or patients in whom perioperative risks might be great because of comorbid diseases. We anticipate that there'll be a major announcement within the next few weeks comparing the relative benefits to stenting and endarterectomy in a large head-to-head North American trial. So keep posted for that. I'm sure it will be big news, as it may provide us with additional options, endarterectomy versus stenting.